As you know, there's a number of practitioner groups who are suggesting that we either reduce opioid use or completely eliminate opioid use, or change the opioids that are currently available on the market to reduce the milligram quantities that are in the extended release products. So I think that first it's important to recognize that opioids are an essential part of the armamentarium for any medical care in patients who have chronic or acute pain syndromes, particularly those that do not respond to other medications. So I'm not suggesting that opioid be the first thing we pull off the shelf to prescribe to patients. And what I am suggesting is that we need to look to the future to develop new molecules that are either opioid-based with less toxicities or completely different pharmacological mechanisms. The question often comes, well, what should we do now if we're going to reduce opioid use? And I think that's a fair question. And the best way to address that is to use rational polypharmacy. And I really want to preface that by saying we don't want to give a bunch of drugs to a patient if it's not rational, right? Because that's irrational polypharmacy. But it's smart to give a patient first non-opioids, but to build upon those. So for instance, we can give a patient 1, 2, or even 3 medications, but it's important to select medications that pharmacologically work very different. The purpose for that is that you can use very low doses of several agents, and all combined by varying the pharmacology, you can actually get a better analgesic outcome with much less toxicity because you're not giving a big dose of one drug.